Thank you.
Por favor.
Most of what I'm going to say about conversion of hip fusion has already been said by Miguel Cabanela, and I agree with everything he says. So I'm going to do this very quickly, and if I have time at the end, I'm going to say a few words about Down syndrome. So the indications for conversion of a hip fusion are patient dissatisfaction, pain in the knee on the same side, contralateral hip, knee on the other side, and the back, and leg length discrepancy. The problems and the complication rates, and this is just looking at a whole lot of papers, can be as high as 24%. Dislocation rates, as you see, 0 to 5%, nerve injuries, heterotopic bone, just having a stiff hip, and very important, a lurch after conversion. And the surgical technique is challenging, and the surgically fused hip is more difficult than the spontaneous fusion. So, for dislocations, there is definitely a higher dislocation rate. And you could use a large head, a constrained cup, or you could brace the patients for 3 months after the surgery. Nerve injuries are definitely more common after takedown of a fusion, so you have to decide whether you're going to identify the nerve early and protect it or just avoid it completely. And a lot of these patients are short, so you have to be aware of how much you want to lengthen the leg before you get into trouble with the sciatic nerve. So, if the hip was fused before growth was complete, then 2 to 3 centimeters is your maximum lengthening. I'm being very conservative here. If after growth was complete, you can lengthen up to 4 centimeters and maybe even longer, as long as the sciatic nerve is of a normal length. Identify the nerve, check the tension in the nerve in flexion, and then very slowly in extension, and don't dissect out the nerve. Just make sure you can feel it and you can see it, because a lot of stuff back there feels like the sciatic nerve, so you have to see it. And what we do in situations where we lengthen over 3 centimeters, we always do a wake-up test. And it's easily done as long as the patient understands it and the anesthetist understands it. Heterotopic bone can be a problem, so we prophylax these patients with 200 milligrams of Celebrex twice a day for 14 days. Stiffness can be a problem, and these patients never regain a real good range of motion, but they have better motion, obviously, than they do with an ankylosed hip. We do some passive range of motion post-op, and of course, muscle strengthening. Gait, and this is very important. I know Miguel already touched on this. The patient that comes in with a fused hip has a limp, but they don't have a lurch. They have a limp, but it's not a lurch. After you do the takedown, because their abductors have not been used and they're very, very atrophied and they're almost non-functioning, they will have a lurch. And you have to tell them about that and tell them that most likely they will require a cane, and you'll see from our data. So the surgical technique that we use, we always do a trochanteric osteotomy because we like to be sure where we are relative to the lesser trochanter, and we can feel it much easier. We identify and we protect the sciatic nerve. The sciatic nerve is definitely at risk. And we use an outrigger in the iliac crest for offset and leg length. We feel the lesser trochanter to make a pre-templated neck cut according to the other side. We start reaming the acetabulum at the correct level, and Miguel said this yesterday, if you have to take an x-ray, take one. It'll delay you by 10 minutes, but it's worth it. And then we use a drill hole and a depth gauge, the same technique that I showed you on the video, to see how far we can ream. So we like to ream within 2 or 3 millimeters of the inner cortex. We usually use an uncemented cup, and we use an uncemented femur, long porous coat, or modular if we had to remove a plate from the femur. And we use a large head or a constrained cup. Now, this is our data. We've now done probably about 25 of these, but this was a publication back in, I don't see the year here, but it was a few years ago. We had 18 hips with a mean follow-up of 5 years. And the indications for surgery were 2 patients actually fractured their femurs below a hip fusion, and 16 had the other indications, mainly pain. So that's what our Harris hip scores look pre-op and post-op. Range of motion, 66 degrees of flexion, not great, but better than 0, and so forth. 15 of 18 required external walking aids. So only 3 people didn't require external walking aids, but pre-op, none of them required external walking aids, so you have to warn the patient. Leg length discrepancy, pre-op average was 3 centimeters and post-op was 1 centimeter. X-rays, no femoral loosening, 1 acetabular component is loose. Complications, heterotopic ossification, 7 of 18. You could see that only 1 had grade 4, but we had 7 patients with heterotopic bone formation. But in this particular study, we did not use prophylaxis. So now today, based on this data, we use prophylaxis. We've had 4 complications, a loose cup in 1, the grade 4 heterotopic bone, 2 nerve injuries, 1 made a complete motor recovery but had residual paresthesia, and 1 still has paresthesia. We've had 2 failures, 1 loose cup, 1 awaiting revision, and 1 heterotopic bone that required excision of heterotopic bone followed by radiation. Examples, this is the most difficult. The surgical fusion is very, very difficult. That's a difficult technical operation. This isn't, and here's a case that was fused in much too much abduction, and you can see that here we actually had to use a trabecular metal augment because we could not get good coverage of the cup. And here is a case of a fracture below a hip fusion. Now this lady was actually booked for internal fixation of that fracture, and I went up and I talked to her and I said, would you rather have your hip fusion conversion and then we could fix the fracture at the same time as you see here? And she said, oh, I didn't realize you could do that. So we actually fixed the fracture, and then as a very big bonus to her, we actually converted the hip fusion. So conversion of a hip fusion to total hip replacement is worthwhile, I think, with improved function and less pain, but you may have to use a large head or a constrained cup if you can get absolutely rigid fixation of your cup. Otherwise, you should use a large head, and when ingrowth occurs into the cup, if the patient is still dislocating, you can convert it to a constrained liner. Heterotopic bone prophylaxis, and be very, very careful about the sciatic nerve. Now, I think I have time to say a few words about Down syndrome because this is one of my favorite topics because these patients present with total hip replacements and are often turned down. That's a publication from 2010, and I have a more up-to-date publication. The incidence of Down syndrome is 1 in 1,000 live births. The problems orthopedically are they have ligamentous laxity and muscular hypotonia. So that leads to subluxation and dislocation of the cervical spine, so the anesthetist has to know that, the knees and the hips. And there is an increased incidence of slipped capital femoral epiphysis and Perthes disease. So, if you look at that again, A plus B plus C equals an increased incidence of osteoarthritis in these patients at a young age. And the incidence is from 8 to 28%. The factors favoring hip arthroplasty are they have an increased life expectancy from 12 in 1949 to 60 today. So they have a very good life expectancy. They have improved health care, and now we have improved biomaterials that allows us to do this surgery. The factors compromising hip arthroplasty are as follows. Compliance, they are non-compliant, they're young, they have cardiac abnormalities, they have cervical instability, and they're prone to infection. So those are what is against doing a hip replacement. Hip-specific factors that are against doing a hip arthroplasty are instability, dysplastic acetabulum, a deformed femoral neck, a very narrow femoral canal, and it is technically challenging surgery. So what I'm trying to say to you is it is definitely worth considering doing a hip replacement, keeping in mind these parameters in this patient population. So the surgical challenge, instability. You have to use a large head, or you can use a constrained cup once. You can use it initially if you can get rigid fixation, or after ingrowth occurs if you are still getting dislocations with a large head, or you could brace them, which probably is not a good idea in this population. When we do a constrained cup, we tend to use trabecular metal because we get better fixation, but you have to get absolutely rigid fixation. If you can't achieve it, do a large head and then revise to a constrained cup if necessary after ingrowth occurs. For dysplasia, be prepared to graft the acetabulum, cut the neck short at the upper level of the lesser trochanter to decrease anteversion and decrease the need for a subtrochanteric osteotomy. And you need small, straight femoral components, and we use the Wagner CDH component. So here's an example. This is a type 2 dislocation by the Greek classification, which I like to use. And here you can see that we've had to use a shelf graft on one side and a constrained cup. And on the other side, we didn't need a shelf graft, but we did a constrained cup. Compliance. The caregivers are the most important members of the healthcare team, and it usually involves one or both parents and a special needs social worker. At least in Canada, we have a very, very good, I'm sure you have it here too, social support system with patients with Down syndrome. So our data is 9 patients, 7 hips. The average age at surgery you could see is very young, 34.8. 7 patients had dysplasia, type 2 and 5, type 3 and 2, slip capital femoral epiphysis and 2, and our follow-up is almost 10 years in this cohort. We did clinical and radiographic follow-up, 6 weeks, 6 months, and then annually, and then we used an HSS scoring system. So on the acetabular side, we look for acetabular migration, lucent lines, and osteolysis. On the femoral side, we look for subsidence, varus, valgus, tilt, and so forth, lucent lines. Loosening equals migration of the acetabulum of over 5 millimeters, of the femur over 3 millimeters of subsidence, or varus valgus shift of 3 degrees. Our implants are uncemented, proximal porous-coated femoral components, porous-coated acetabular components, and a constrained liner was used in 6 of 9 patients. Our approach was usually a trochanteric slide or a transgluteal approach. We use no braces and no spicas. Our HSS scores improved, as you can see, from 41 to 85.2. In 5 of 7 patients, there was no external walking aids. 1 patient used a walker, and 1 patient used a cane. 7 of 9 patients were perfectly stable on both sides. 2 patients were revised for stem loosening, 1 at 6 years, and that was as a result of a periprosthetic fracture, and 1 at 16 years. 2 revisions doing well at 7 years and 6.1 years. So I think that's a very respectable revision rate. A periprosthetic fracture required stem revision at 6 years. We've had no dislocations and so far no infections. And those are the 2 main complications that you have to look for in this population. Now, this is our most recent article, and this was a multi-center study that comprised 25 patients, but I'm not going to go through all the data. It's exactly the same as our data. So I want to emphasize that Down syndrome is definitely, they do have hip problems. You should consider them for hip replacement, particularly if they have a good support system. For me, this is like, it's almost like a pet project of mine. I see patients with Down syndrome, and I usually, if they have severe osteoarthritis, I usually go ahead and do the surgery, and I think our results can justify that. So thank you once again for inviting me to this absolutely gorgeous city.